This is part of a series I call the Making Evidence-Based Medicine Simple series, or MESS for short. In MESS Minis, we review an essential EBM concept. In this MESS Mini, we will review diagnostic test characteristics. We will discuss sensitivity, specificity, and predictive values. A separate MESS Mini reviews likelihood ratios. At the completion of this presentation, you will be able to interpret sensitivity, specificity, and predictive values of a positive and negative test in a clinical context, and understand the limitations of sensitivity, specificity, and predictive values of a positive and negative test in determining a specific patient's post-test probability of disease. We will use the results of a study conducted by Lane analyzing the accuracy of a non-contrast CT scan of the abdomen and pelvis in the identification of appendicitis. The population is primarily adult patients with suspected appendicitis. The intervention is a non-contrast CT scan of the abdomen and pelvis. The criterion or reference standard is the operative report, pathology report, or clinical follow-up. And the outcomes are the test characteristics of the non-contrast CT scan. Essentially, we use tests with a positive and negative outcome to allow us to stratify patients into high and low risk groups. The test characteristics, sensitivity, specificity, predictive values, and likelihood ratios help to assess how well the diagnostic test accomplishes this risk stratification. After assessing disease probability in my patient and deciding which test to order, I find it helpful to think about the specific test results that I need in order to make clinical decisions about the disease probability of my patient. The two clinical questions are, what is the likelihood of appendicitis if the CT scan is positive? And what is the likelihood of appendicitis if the CT scan is negative? It is important to understand the impact of the answer to these questions on management of the patient for each test result before ordering the test. We will keep these questions in mind as we review the test characteristics. This is a standard 2x2 table for a diagnostic test accuracy study. The disease, as determined by the reference standard, goes on the top and is divided into those with disease and those without disease in the columns. The test goes on the side and is divided into positive and negative test results in the rows. Notice that I didn't use the terms true positive, true negative, false positive, and false negative. That was intentional. I find they add more confusion than clarity to the process, so I try to avoid them whenever possible. The concordance cells in the 2x2 table represent agreement between the test and the diagnosis. We want most of the data to be in these concordance cells. The discordant cells in a 2x2 table represent disagreement between the test and the diagnosis. We want very little of the data in these discordant cells. This is our study data. Determining the marginal totals will give us a better picture of our population. There are a total of 300 patients in the study, 115 with appendicitis and 185 without appendicitis. The CT scan was positive 114 times, and the CT scan was negative 186 times. The marginal totals allow us to complete the simple calculations of the test characteristics. The first thing I like to do is calculate the disease prevalence. In this study, it is the percentage of total patients that had appendicitis. That is 115 divided by 300, or 38%. Note that the prevalence is calculated horizontally. This is important. Test characteristics that are calculated horizontally, such as predictive values, will be affected by changes in prevalence. Test characteristics that are calculated vertically, like sensitivity and specificity, will not be affected by changes in prevalence. We will first look at sensitivity and specificity. Sensitivity is the percentage of patients with the disease who test positive. Specificity is the percentage of patients without the disease who test negative. In the appendicitis study, the sensitivity is defined as the percentage of patients with appendicitis who had a positive CT scan. In this case, it is 110 out of 115, or 96%. Note that the sensitivity is calculated vertically and is therefore not affected by changes in prevalence. In the appendicitis study, specificity is defined as the percentage of patients without appendicitis that had a negative CT scan. In this case, it is 181 out of 185, or 98%. Again, note that specificity is calculated vertically and is therefore not affected by changes in prevalence. We have been taught these concepts frequently throughout our training and yet still have difficulty understanding their meaning when applying them to patient care decisions. I find it very helpful to try to use the results in a sentence using the study parameters. If you can't say it in a sentence using the study parameters, you will have difficulty applying it clinically. Start with the percentage, then the denominator, and end with the numerator. For example, the percentage of the patients with the denominator had the numerator. We will use this template for sensitivity, specificity, and predictive values. Let's try using the sensitivity and specificity results in a sentence using our template. For sensitivity, 96% of the patients with appendicitis had a positive CT scan. For specificity, 98% of the patients without appendicitis had a negative CT scan. Unfortunately, sensitivity and specificity are disease-oriented and not patient-oriented. They tell us how well the test identified those with disease and without disease, but they don't answer the two questions that we need to know to make clinical decisions. Specifically, we cannot determine our patient's post-test probability of appendicitis if the CT scan is positive, and the post-test probability of appendicitis if the CT scan is negative from the sensitivity and specificity. When interpreting sensitivity and specificity, it's important to consider the possibility of spectrum bias. Spectrum bias may occur when there is varying disease severity that may affect the interpretation of the diagnostic test. For example, let's look at two hypothetical study populations. The first is a population with a prevalence of appendicitis of 20%. Those with appendicitis had a 10% rate of perforation with abscess formation. The second is also a population with a prevalence of appendicitis of 20%. But in this population, those with appendicitis had a 50% rate of perforation with abscess formation. The difference in the rate of perforation with abscess is an example of the difference in the spectrum of disease. It is easier for CT to identify those with a large abscess compared to those without a large abscess. Because of this, the sensitivity in the population with a higher abscess rate may be higher than the sensitivity in the first population with a lower abscess rate. We will next look at the predictive values. I prefer the term predictive value of a positive test rather than positive predictive value because predictive value of a positive test reminds me that the positive test is the denominator. Predictive value of a positive test is a percentage of patients with a positive test with the disease. Similarly, I prefer the term predictive value of a negative test rather than negative predictive value because it reminds me that a negative test is the denominator. Predictive value of a negative test is a percentage of patients with a negative test without the disease. Let's calculate the study predictive values. The predictive value of a positive test is a percentage of patients with a positive CT scan that had appendicitis. In this case, it is 110 out of 114, or 96%. Notice that the predictive values are calculated horizontally, so that the predictive values will be affected by change in prevalence, which is also calculated horizontally. More on this concept in a bit. The predictive value of a negative test is the percent of patients with a negative CT scan that did not have appendicitis. In this case, it is 181 out of 186, or 97%. Again, note that predictive values are calculated horizontally, so they will change if prevalence changes. Again, let's try to use the predictive values in a sentence. We will use the same template that we use to express sensitivity and specificity. The percentage of the patients with the denominator had the numerator. Predictive value of a positive test is 96% of the patients with a positive CT scan had appendicitis. Predictive value of a negative test is 97% of patients with a negative CT scan did not have appendicitis. Predictive values are patient-oriented. They provide post-test probability of disease, but only for those with the study pre-test probability or prevalence. The predictive value of a positive test indicates the probability of having appendicitis in those with a positive CT. This is 96%. The predictive value of a negative test indicates the probability of not having appendicitis in those with a negative CT scan. This is 97%. The predictive value of a negative test gives us the probability of not having appendicitis if the CT scan is negative. We want to know the post-test probability of having appendicitis if the CT scan is negative. To get the post-test probability of having appendicitis if the CT scan is negative, subtract the predictive value of a negative test from 1, or 100%. There are only two possibilities if the test is negative: having appendicitis and not having appendicitis. The probability of having appendicitis if the test is negative and not having appendicitis if the test is negative adds to 100%. In this case, the post-test probability of having appendicitis if the CT scan is negative is 1 minus 0.97, which equals to 0.03, or 100% minus 97%, which equals 3%. This makes sense. If you have a 97% chance of not having appendicitis if the CT scan is negative, then you have a 3% chance of having appendicitis if the CT scan is negative. The predictive values allow us to stratify a patient population with a 38% pretest probability of appendicitis into high and low risk groups. If a CT scan is positive, the post-test probability of appendicitis is 96%. If the CT scan is negative, the post-test probability of appendicitis is 3%. Unfortunately, these predictive values only apply to patients with a 38% pretest probability of appendicitis. They can't be used to determine the post-test probability of appendicitis in our patient who had a pretest probability of 20%. For that, we need likelihood ratios, which are discussed in a separate MES Mini. This slide illustrates how the predictive values change as prevalence changes. On the left is a study population with a prevalence of 100 divided by 200, or 50%. On the right, I doubled the number of patients with appendicitis in the study so that the prevalence increased from 50% to 66%, or 200 divided by 300. Note that the sensitivity, specificity, and likelihood ratios are the same in both studies. In the study with a higher prevalence, the predictive value of a positive test increases, and the predictive value of a negative test decreases. Remember that a decrease in the predictive value of a negative test represents an increase in the post-test probability of disease with a negative test. It makes sense that the higher the pretest probability of disease, the higher the post-test probability of disease given a positive or a negative test result. Put another way, the more likely you are to have appendicitis before the test, the more likely you are to have appendicitis after the test, whether that test is negative or positive. In calculating sensitivity, specificity, and predictive values, the denominator is always one of the marginal totals. For sensitivity, the denominator is those with disease. For specificity, the denominator is those without disease. For a predictive value of a positive test, the denominator is those with a positive test. And for predictive value of a negative test, the denominator is those with a negative test. In calculating sensitivity, specificity, and predictive values, the numerator is always one of the agreement or concordant table cells. These are the cells in which the test is positive and the disease is positive, or the test is negative and the disease is negative. For sensitivity and predictive value of a positive test, the numerator is those with a positive test and a positive disease. For specificity and predictive value of a negative test, the numerator is those with a negative test and a negative disease. Confidence intervals are a measure of the precision around a point estimate. They can be thought of as a range of possible values for the point estimate. In this case, the point estimates are the test characteristics. Confidence intervals are related to sample size. The larger the sample size, the narrower the confidence interval and the greater precision of the point estimate. Confidence intervals are typically expressed as the point estimate with a 95% confidence interval with a lower limit and an upper limit. There is 95% confidence that the point estimate will fall between the upper and lower limit of the confidence interval. Note that the upper limit of the confidence interval for sensitivity, specificity, and predictive values cannot exceed 100%. Here are the 95% confidence intervals for the study test characteristics. In this example, there is 95% confidence that the sensitivity of 96% will fall between a lower limit of 90% and an upper limit of 98%. You may have been happy with a sensitivity of 96%, but not so happy with a lower limit of sensitivity of 90%. In most diagnostic test studies, there are fewer patients with disease than without disease. This results in a larger confidence interval around the sensitivity than around the specificity. In most diagnostic test studies, there are fewer patients with a positive test than with a negative test. This results in a larger confidence interval around the predictive value of a positive test than around predictive value of a negative test. All three types of test characteristics have some limitations. Sensitivity and specificity are disease-oriented, not patient-oriented, so you can't determine your patient's post-test probability of disease from them. Predictive values are patient-oriented, but are affected by prevalence and don't give you the post-test probability of disease for your specific patient. Likelihood ratios are odds and not probability, but can be easily converted using the nomogram to give the post-test probability of disease in your specific patient. More on likelihood ratios in a separate MESS Mini. The last thing I want to address is the process of ruling in and ruling out disease, and review the parameters that allow us to do this. To rule out disease, you would like a low post-test probability of disease. Post-test probability is equal to the pretest probability times the likelihood ratio. You can get a low post-test probability of disease with a low pretest probability, a negative test result, and a small likelihood ratio of a negative test. A small likelihood ratio of a negative test can be obtained with a high sensitivity, hence the term SNout for sensitivity, rule out. To rule in disease, you would like a high post-test probability of disease. Post-test probability is equal to the pretest probability times the likelihood ratio. You can get a high post-test probability of disease with a high pretest probability and a positive test result, and a large likelihood ratio of a positive test. A large likelihood ratio of a positive test can be obtained with a high specificity, hence the term SPIN or specificity, rule in. In summary, a diagnostic test can't affect your management strategy if you don't have a management strategy to begin with. A strategy requires an understanding of the pretest probability of the patient, testing and treatment thresholds for the disease, and the test characteristics, and in particular the likelihood ratios. It is important to determine what you will do with both a positive and a negative test result before you order the diagnostic test. Practice using the test characteristics in a sentence using the study parameters. This is the only way you will become comfortable with them clinically. In other MESS Minis, we review other aspects of diagnostic testing. This includes MESS Minis on diagnostic testing thresholds, likelihood ratios, and receiver operating characteristic curves.